Good morning, and welcome back to Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce our own Dr. Jill Farmer. Dr. Jill Farmer is an assistant professor of neurology at Drexel University College of Medicine and director of the Parkinson's Disease and Movement Disorder Program at Global Neurosciences Institute. She's board certified in neurology. As the first movement disorder specialist with GNI, Dr. Farmer has developed a comprehensive movement disorder program to address medical management, surgical management, and rehabilitation strategies for patients with Parkinson's disease and other movement disorders. Dr. Farmer developed clinics for botulinum toxin therapy to treat dystonia and spasticity, as well as deep brain stimulation to manage Parkinson's disease, essential tremor, and dystonia. Dr. Farmer was the first movement disorder specialist in New Jersey to use DUOPA, the new surgical intervention for Parkinson's disease. Dr. Farmer received her medical degree from University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine and Master's in Public Health degree from University of Medicine and Dentistry of New Jersey Robert Wood Johnson School of Public Health. And Dr. Farmer will be reviewing tremors today. Dr. Farmer.
Thank you very much. Let me share my screen. And slideshow from start. Okay, so we're going to talk about tremors today. This is sort of my algorithm of how I start to differentiate a tremor when I see somebody walking into my office. I like my specialty because I can make many a diagnosis just by observing people as they walk by, and then kind of confirm it as I hear the history and do a little bit more of a detailed physical exam. But from the start, if it's rhythmic and oscillatory, then it's a tremor. If it's not, if it's jerky, if it's large amplitude and very irregular, if it's more sinuous and kind of dance-like and things like that, those are not tremors. It's got to be rhythmic and oscillatory. It can be large amplitude, small amplitude, fast, slow, fine, not fine, but those are the keys that make it a tremor. So if it is a tremor, then is it a rest tremor or an action tremor? If it's happening when the patient is not realizing it and they're just sitting there talking to you, it's Parkinson's really until proven otherwise. There are other things that can be a rest tremor, essential tremor of the head, dystonic tremor of the head, mostly a Holmes tremor, things like that. But if it's a rest tremor, common things are common and it's Parkinson's until proven otherwise. Now, if it's an action tremor, it's got a larger differential. So if it's postural, it can be physiologic, orthostatic, psychogenic. If it's with action, it can be intention, dystonic. If it's task specific, those are sometimes the easiest because it's so finite and discrete, then that's a dystonic tremor. And if it's isometric, these are the kinds of tremors that happen during exercise, like someone stretching and they'll say their muscles will shake or their hand will shake, their leg will tremor, things like that. And that's really when there's the strain on the muscle. And that's called an isometric tremor. Not a tremor we're not talking about today, but just thinking about if it is one of those things that is not rhythmic, large amplitude, very jerky, it can be tics, it can be chorea, it can be stiff person syndrome or spasticity. So there are other things that move weird that are not tremors. And everybody has a tremor. And I tell this to a lot of my patients. Everybody hums at a certain rate. Some people will hum and vibrate more. Some people will hum and vibrate less. As you get older, you compensate less. So there is tremors that emerge, and it's not always Parkinson's disease. But one of the things that can impact a tremor is external factors, so tone and weight, which is why weighted utensils, wrist weights, using muscle relaxants, things like that can help with the impact of the tremor. Changing the body mechanics, changing how the arm is positioned, particularly for a writer's tremor or things like that, that can change the tone. And these can help with the frequency of the tremor and the amplitude of the tremor, which is really what's most problematic for patients. And when I'm speaking to patients about tremor of any kind, I tell them our goal is not to make your tremor go away, it's to make it more manageable. It's to make it so that you have to adapt less, but you still will likely have to have some adaptation or some intervention to manage the tremor if it's bothersome enough. And tremors come from two axes. It is central or peripheral, which is why impacting the tone, impacting weight, things like that can make a difference. So you have the central oscillators that, direct movement down through the spinal cord, and that's the central loop. And then you have the spinal cord to the muscles, and that's the peripheral loop. If you can intervene at any point in this pathway, then you have the opportunity to impact or improve a tremor. And this is a very gross overview, but a nice kind of ways to compartmentalize it in your head of what impacts tremor in different ways. So the motor cortex can be the driver of the tremor, the putamen can be the onset of the tremor, and the cerebellum and the VIM can be the amplitude of the tremor. And that makes sense, the last one in particular, for things like essential tremor. So where there was the initial target for deep brain stimulation for essential tremor, the VIM. So speaking about Parkinson's tremor, we always have to, do our due diligence and mention the direct and indirect pathways, but it is mostly for me to tell you to think about them and then forget about them when it comes to tremor. So the direct pathway drives movement. The indirect pathway inhibits movement, DDII. And dopamine has its impact by driving the direct pathway and inhibiting the indirect pathway. So if you have low levels of dopamine, you lose that drive of the direct pathway, so difficulty initiating movement, and you lose that inhibition of the indirect pathway, so you have more difficulty with, rigidity, bradykinesia, things like that. But again, nowhere in that oversimplified schematic does it mention tremor, and that's because tremor, we don't know the exact pathway and physiology of tremor. We gave you the brief overview in the slide before, but there are, oscillating networks within the cerebellum that have an impact on tremor. That's why you can give patients with Parkinson's disease as much dopamine as you can throw at them as they tolerate, and that tremor may not go away. So it's not simply controlled by the direct and indirect pathway or the impact and influence of dopamine. There are some Parkinson's patients that have more of an action tremor than a rest tremor. It's more of a mixed tremor picture. So it's never quite as simplified as the textbooks would like it to be. So here are some videos, and these are the types of tremor in Parkinson's disease. The classic tremor is the rest postural tremor, and then with a low frequency, low amplitude. The resting tremor for the type 2 can have a slightly higher postural or kinetic component. So that's when their hands go more like this when they hold them out straight. And then type 3 is really no rest tremor at all, and it's purely postural kinetic. And these are often the patients that are late to see us because they've been diagnosed as ET, appropriately so, because clinically that's what it looks like. But then they start to have other phenotypic symptoms on their clinical exam that makes you think more Parkinson's. So this is Parkinson's.
Have you relaxed? Close your eyes and count backwards from 20.
20, 19, 8.
Yeah. All right, both your hands like that. Both your hands like that. No, opposite, yes. And now both your hands like that. And relax. And
so you could see she has the masked faces, the decreased blink reflex. She's got that persona of Parkinson's, and her tremor is unilateral, one-sided, low amplitude, moderate frequency. But the thing that is also most telling in this exam is the phenomena of reemergence. So whenever she moves, that tremor goes away. And then as she holds out a posture, whether it's her hands extended, palms down, or palms forward, or whatever it might be, it takes a beat, and then that tremor comes back. And that's called reemergent tremor. And that's something that is, diagnostic more than not of Parkinson's disease on a clinical exam. And that's because after you hold a posture for a it like, it doesn't have to be literally 60 seconds, but after you hold your posture for a beat or two, it's then considered rest, and that rest tremor reemerges, and that's what that is. So for essential tremor, again, we don't know the exact pathophysiology of ET. There is a lot of hypotheses, and these are the leading hypotheses that we have. And probably of these three, the one on the bottom, the oscillating network hypothesis, is the one that is, probably has the most favor amongst movement disorders. There is this idea that it might be neurodegenerative in a very slow way. And the reason for that is there's a progression of essential tremor as you get older, initially thought to be less compensation as patients age, but there's other things that come into it. There is some memory problems that come in with essential tremor patients. There's balance problems, things like that. And these are also because the cerebellum is a key component in memory and in balance and body position in space and things. So they also notice pathophysiologically that there are Lewy bodies that can be seen in the locus coeruleus, not to the same extent that we see them in the nigrostriatal degeneration pathways, but they are there. So this has some potential as being a working hypothesis for essential tremor. The GABA hypothesis was really a hypothesis by treatment. So we gave patients medicine to increase GABA, primidone, alcohol, things like that. And patients tend to do better. Their tremor response, not everyone, but some. So that's how that hypothesis came into favor. And like I said, the oscillating network hypothesis is really just this out of whack hyperpolarization between the thalamus, inferior olive cerebellar nuclei that don't quite get it together. And like I said, from a electrodiagnostic point of view, from the studies that they've done, this seems to be the one that holds true for the majority of patients with ET. So I said, the differential of rest tremor is rather small, Parkinson's until proven otherwise, but differential of action tremor is larger. And so that's what we'll focus on today. Essential tremor is the most common tremor, not Parkinson's. So if it's an action tremor, common things are common, you're thinking essential tremor, and you're going to try those medicines, like we said, from, for decades that have always been tried. That has not changed. Propranolol, primidone, see if it makes a difference. If it's not, or if you're kind of getting the feeling that there might be a little bit more on physical exam than just an action tremor, then it might be tremor predominant PD. And these are patients that can have tremor for years. I get the story, I was diagnosed with essential tremor 15 years ago, and I've just been kind of dealing with it. And then I see them and I do an exam and they have slowness and rigidity and things like that. And I'm like, well, I think it was actually tremor predominant PD that was brewing. It progresses exceptionally slowly. And I tell that to patients that if you had to pick a Parkinson's to get, tremor predominant Parkinson's would be the one, because it has the least amount of comorbidities associated with it within the Parkinson spectrum. The problem is their tremors tend to be medication refractory. So these are the patients that we're sending for surgery if caught sooner rather than later. But that patient that saw me 15 years in is still a candidate for surgery. Like I said, task-specific dystonia, seen in musicians quite commonly, seen in writer's cramp. That seems to be one of the most common ones that, not related to a profession or overuse or things like that. Enhanced physiologic tremor, I diagnose all the time. That's that generalized fine, fast tremor that someone has. It can be seen in people with anxiety or on medications that they either take for mood or stimulant or whatever it might be. Medicines for seizures, or mood disorders, lithium, Depakote, things like that can enhance the physiologic tremor, along with a drug-induced action tremor, same sort of thing. And then on the bottom of the differential are things that are there for good measure, but really are rarely seen. Wilson's, I've only seen one, and that was in fellowship. And FTAS, I have thought about, and we'll talk about it a little bit, and I've sent the genetic panel, but have yet to actually diagnose it. So we'll play two tremors side by side just to see the difference between essential tremor and Parkinson's tremor. So he has tremor in both hands with action. Hers stops with action, reemerges after she holds the posture and puts it up. She also, again, has that masked face like I was talking about, but you could see her tremor looked a little bit different than the Parkinson's tremor that we saw in the first lady. It was a little bit more jerky on both sides, a little bit variable in amplitude, where the woman's was so rhythmic and so oscillatory. It was quite easy to see. And here's kind of another chart algorithm, however you want to think, to kind of parcel the most common features of the different types of tremor to help you with your differential. So if you're looking for a tremor at rest, like I said, it's tremor predominant Parkinson's, but you can see some of the others have it, especially someone with long-standing ET. Now, again, I said I have that patient that comes in, they tell me they've had tremor for 15 years. I see other things on exam, I'm thinking it's tremor predominant. I have a patient that comes in, they've had tremor for 30 years. They definitely have a rest tremor of the head at this point, but they really don't have anything else on exam. There's no cogwheeling, there's no decrement, there's no slowness. That writing sample is still most consistent with an essential tremor picture. They have essential tremor. And those patients can have a little bit of cogwheeling, a little bit of increased tone if you check, but not to the same degree as someone with Parkinson's disease. Tremor with action, essential tremor, and that's where the F-tasks come in. So that is usually seen, say, in someone with a really coarse action essential tremor, and there's a family history of both sides of men and women in the family that have tremor, along with some history of psychological or cognitive issues. Then you might be thinking this might be that picture, especially if it's refractory to medication. A task-specific action tremor, like I said, a dystonic tremor, but it can be seen in anyone with an action tremor, because action tremors, when you're using your hand, tend to make the tremors worse. But if it really only happens with one specific thing, just with writing, just with, playing the flute, or, for the mouth, just with embouchure of an instrument, then that's like a task-specific dystonia. We talked about cogwheeling. And cognitive balance and ataxia can be seen with many. It is an essential tremor, again, because of the cerebellum. Tremor predominant Parkinson's, not as much. And we know that balance is something that is typically seen with Parkinson's disease. But remember, these patients really just have the tremor. That, like the other comorbidities, the other clinical symptoms that we see, are not quite as pronounced for these patients. And then as far as lab tests and biomarkers, there really isn't any lab tests that's specific. There is a DAT scan. A DAT scan is a test that looks at how well the brain is metabolizing and utilizing dopamine. And if there's a deficiency in it, then that gives us the biomarker to say that this tremor falls somewhere on the Parkinson spectrum. It doesn't stage it. It doesn't differentiate between a tremor predominant, an akinetic rigid, a gait postural instability, gait predominant type of Parkinson's. It doesn't tell us if it's a typical or an atypical Parkinson's. So someone with MSA that is a close mimic that might have a tremor and looks Parkinsonian but isn't quite responding to medication. All it tells us is that there's a dopamine deficiency present, and that is a likely contributor to the tremor that we're seeing. So when we evaluate the tremor patient, the thing is you want them to do the thing that brings out the tremor. And so it is important to, if you're going through your exam and you're just doing finger to nose and you see that little bit of intention tremor, or you see that rest tremor while they're sitting, that's helpful. But if they're telling you like, this really happens when I write, or when I pour something, or when I do this, have them do the thing that brings out the tremor so that you can really get a visual of what it looks like and how impactful it is. Other things to think about just by getting the history is obviously the medications they're taking. I touched upon this. There are a number of meds that can enhance a tremor, steroids especially. Get their diet history. Are they drinking like 12 cups of coffee a day? Are they wearing a nicotine patch and still smoking? Like, these things can absolutely have an impact on the tremor. Do they have any other medical conditions, thyroid issues, whatever it might be? And of course, family history to see. Tremors aren't necessarily painful. So if they are describing a discomfort or a pulling or a need to kind of be in one particular posture or an urge to do something, then that can also say, is this a more of a tic? Is it a dystonia? So these are sort of the ways that we kind of tease out under which umbrella the tremor may fall, if it's not something that is so obvious that you diagnosed it when they were walking into the room. And again, this is what I was saying before about making sure they do the thing that brings out the tremor. The other thing to take note of on the exam is distractibility and entrainment. And this is not because you're trying to catch somebody in a lie or trying to prove that their tremor doesn't really exist or anything like that. But the notion of a functional tremor, formerly called psychogenic or conversion or things like that, is, I'm sure, something everybody is seeing in these clinics these days, especially post-COVID and post-vaccine and everything else. And there are nice ways to kind of approach this by pointing out positive clinical findings on physical exam that is not accusatory, or, you know, you're not left by saying, well, this is all in your head sort of a thing. It's all caused by stress. That's not to say that these statements are false, but you can see how this would fall on deaf ears for somebody that might not be ready to hear it. So the way that you phrase it and the way that you couch it is quite important. So if you can show distractibility and entrainment on an exam, that's a nice segue into being able to say, well, let me explain why your body is doing this. Let me talk to you about processing and how your brain can't do two things at one time, no matter, you know, how intelligent and how smart our brains are. And what distractibility and entrainment is what you saw in that first video where the doctor was asking the patient to count backwards. That's the simplest way to elicit distraction on an exam. Close your eyes. You're taking the visual input out so that you're not seeing it. Count backwards from 100. And if they're doing this and that tremor changes, and it doesn't have to be a drastic change, but an obvious change, it's now becoming more jerky and less rhythmic, or it's moving in the rhythm of their counting, that's entrainment, or it stops completely, that's distraction. These are things that can help you explain, especially if there's another family member or a friend or someone in the room, they'll see it too, and they're not a medical professional, and it's like, oh, okay. The other, if patients have been really entrenched in their tremor and this diagnosis of, you know, something being quite wrong, that might not be enough of a distraction. So you have to then get a little bit more creative and a little bit more difficult. So have them do one thing on one side of the body that is complex while holding their hand out straight or doing something. So, you know, pat your head and rub your tummy kind of a thing. And it is, you can see that there are going to be changes to the amplitude, to the frequency, to the intensity of a functional tremor by eliciting some of these techniques. It's not 100%, it never is, but it is more than not. And like I said, these are the ways that I have found to be most helpful to kind of bridge that divide of, you're the fourth doctor they've seen, everybody's told them they're crazy, and I don't know what to do or what to say. If you can give them some objective finding and then discuss and kind of backtrack from there, it makes it more palatable. And it doesn't always happen in one visit, but at least it sets the stage. And this is exceptionally common, like 30% of all patients that walk into an office of any specialty are going to be functional. This is what a DAT scan looks like. And that it's an exceptionally easy test to read. It's fairly sensitive and specific, like in the 90s. So it's a biomarker that I do use often, and I feel comfortable with speaking to patients about. The one on the left is a normal scan, nice, bright, plump commas. The one on the right is an abnormal scan, and that's really it. If there is any asymmetry, any change from things that look like the nice plump commas, then we have a positive scan. If it's really subtle and you have that like could be, could not be, tremor is mild, okay, in these cases it's not quite as helpful, but we were clearly diagnosing Parkinson's before we had the DAT scan, so you treat the patient in front of you. If they respond to some degree to a levodopa challenge and they have an equivocal scan, I'm going to err that this is a blossoming Parkinson's picture. If there's no response to levodopa and they have an equivocal scan, then I'm going to say, well, I don't think, and we'll just follow clinically that to see if anything else emerges over time. And if time passes and nothing else is emerging, then you can feel confident in saying that this is not part of a dopamine deficiency spectrum. So for essential tremor, again, most common tremor and movement disorder that we have, everybody is familiar with this, have learned it in med school, hasn't really changed all that much over the years of what we do, but things to think about is family history correlates with age of presentation. So if someone starts to develop an essential tremor later in life, they may not have that positive family history that we're all taught about, that it is an action tremor with a larger amplitude. But again, the longer the patient has ET, there can be a rest tremor, notably in the head. That's where it's seen mostly. And there can be a mild increase in tone, like I was mentioning, like a little bit of cogwheeling. These are the patients that you might get a DAT scan on if you're concerned, if they're older, and then either be surprised or not be surprised if it comes back negative because it reinforces what you were clinically thinking. And again, the cerebellum does more than just balance. So this is that idea of the degenerative hypothesis. So there can be some, increasing anxiety, hearing and speech issues, cognitive issues, things like that, as a person with essential tremor ages and starts to develop more pronounced clinical features. So for Fragile X tremor ataxia syndrome, this is, again, for someone who is, think of a woman who might have a very coarse tremor, like I was saying, and they have other autoimmune system disorders. This is kind of where I'm thinking about it as a rarer occurrence, possibly on a differential. But for people that have a combination of tremor, coordination, some Parkinsonism, neuropathy, weakness, autonomic dysfunction, again, if it's not Parkinson's, because this all can be something that we see in a patient with Parkinson's disease, or they're younger, or there's a really strong family history, then you could think of this and send for genetic testing. Like I said, I have yet to make a diagnosis through genetic testing for one, but it is always on my differential. And then for Wilson's disease, this is also something that should be on the differential because it's treatable. And it's you can diagnose it through some clinical exam findings as well as genetic testing. And the earlier you do, the better the treatment will be. So particularly for young individuals that have a combination of some psych conditions as well as abnormal movement disorders, screening tests should be run for copper and ceruloplasm, urine copper, and if needed, then you can go to a biopsy or genetics to confirm. But if you do catch this early and are able to start chelation therapy, they can function quite well and not be left with any permanent movement disorder deficits. So this is what Wilson's looks like. And this is not my patient from fellowship, but looked exactly like this presentation. There we go. So you can see the tremor is slower, more intention type. There's a little bit of dystonia, increased tone. That's the Kaiser-Fleischering. And that's that slurred, scanning, dysarthric speech. Striatal toe. And that constellation of pictures, you even saw when she was speaking, that like little smile, the rhizus sardonicus, that is the motor phenotypes of Wilson's disease. So for the management of tremor, like we said, for essential tremor, honestly hasn't changed. Inderal long-acting, mycilene, primidone. Take a look at the doses. I would say that in my clinical practice, I'm not necessarily going up to the max dose of any of these because of potential side effects, as well as if they're not really responding, I'm starting to look at a combination of interventions or surgical interventions, as opposed to bumping these up all the way. There are second lines. Benzos can be really helpful in tremor. Remember, anxiety is a big component in a lot of these tremors, just part of the pathophysiology, whether it's Parkinson's, whether it's longstanding ET, whatever it might be, social anxiety, just circumstantially. And we're not talking high doses of it, but I will say that as a movement disorder, I probably use benzos more than most. But again, at low doses and with an understanding that this is something we're going to use and try and adjunct with other medications. But if we have to keep increasing the dose, then it's not the right treatment strategy or method. But they can be helpful. And I say that because I know they get a bad rap. I don't tend to use gabapentin. I don't think it's quite helpful in tremor. I know it's always listed as something to use, but as I said, gabapentin or Topamax, they're on there, but I haven't been overly impressed with their clinical with patients' clinical response to them. So for the management of Parkinson's disease, it's been levodopa or some sort of dopaminergic modulation since the late 1960s. If anybody has seen the movie Awakenings, that's the story of the development of levodopa tested on patients with post-encephalitic Parkinsonism. First started with just levodopa, terrible penetrance to the blood-brain through the blood-brain barrier. Then they developed carbidopa to go along with it to prevent its breakdown in the gut, so it wasn't making patients violently ill. And that's how it got its brand name, Sinemet, sin without emesis, throwing up. And that has been the mainstay. The only changes to that is how long it lasts in the system. So they've looked at extended release forms of Sinemet. They've looked at capsular forms and extended release through Rytary. And the latest is a gel form that is infused through the gut, through a PEG-J, through Duopa, the Duopa pump, to avoid the peaks and valleys that we have with patients with Parkinson's, the on-off phenomena. What is coming, what should have come the end of March, but the FDA has delayed it yet again, is a smaller pump for Parkinson's disease. It's the second generation of the Duopa pump. This does not require a procedure at all. This is a subcutaneous pump. Think about like an insulin pump from the 80s. So not as compact and pretty as the pods we have now for diabetes, but much improved from the current Duopa that we have that is, like I said, a PEG-J and a larger device that you have to wear. The medicine itself has not had any issues. That has been approved and everything. What the FDA is asking for now is additional information on the pump itself. And this type of information that they're asking is the extreme situations of like, well, what if it is, exceptionally cold out, like Arctic temperatures? How will the pump function? What if it's exceptionally hot out? And, Amazonian temperatures, how will it function? So needless to say, everybody in the movement disorder community is not a fan of the moment of having this be delayed, because it's already been delayed, but it is coming. Hopefully it is just 6 months away now, fingers crossed. And that really would be quite beneficial because it's a liquid form of levodopa and it's just subcutaneous. No intervention, no surgical intervention or procedural intervention is needed, and it can be worn for 24 hours a day. So you're getting this constant infusion of levodopa to avoid, again, those peaks and valleys, and it is something that a patient can sleep with. The very first medicine that they had for Parkinson's was amantadine. They were giving it to flu patients and found that it helped their tremor. But it's a bit of a dirty medicine. So, it caused side effects, made some people feel like they had the flu, cognitive issues, somnolence. So there's newer formulations of amantadine now by way of Gocovri and Osmolex. I do use these meds. I think they're quite helpful even when amantadine has not been in the past. The hurdle had been coverage and availability. It's still a hurdle to some degree, but far better than when it was first launched. So if it's something that you had used, but kind of got a bad taste in your mouth because of availability, try it again. Coverage is better. and see if it's helpful. And also they have very generous sampling programs if you're allowed to accept samples. The other class of meds are dopamine agonists. These are the meds also used for restless leg, but can be used in Parkinson's as well. And these mimic the way dopamine works in the system. So they're not replacing dopamine. The way levodopa is to some degree, they are mimicking how it works by acting on the same receptors. And they can be oral or they can be injectable. The injectable version is Apokyn, and that's more of an on-demand therapy. So people that have an overall good medication regimen, but are experiencing like a slow start to their day in the morning and they need a little jump start, they can look at Apokyn. If they are thinking that, you know, they want to have something on their person in case their medicine wears off unexpectedly, and they're out and about, they can use this as sort of a bridge. There is also an inhaled form of levodopa, I should have put it on there, I didn't, called Inbrija, which is the same type of idea. It's kind of a bridge therapy, an on-demand therapy if you need to use it. And it has a faster onset of action because it does not go through the gut, but gets absorbed through the lungs. And then Kinmobi is on here, but I should take it off because I just got a letter that they are stopping production of Kinmobi in the United States for PD patients. It was a sublingual strip, same idea of a dopamine agonist being an on-demand therapy, but it just did not get the traction that had been hoped. And then the non-dopaminergic route, again, we do have the amantadine that we were talking about, but the newest one is adenosine. So adenosine, they have found, is quite impactful in the indirect pathway in Parkinson's disease. And while patients with Parkinson's are losing dopamine, they are actually increasing their adenosine receptors as the disease progresses. So if you block adenosine in the indirect pathway, you can have a compounding effect of inhibition of that if you're supplementing with levodopa as well. So basically inhibiting the inhibitor, allowing for improvement of movement. And that medicine is called Neurosciences. And again, I have found it quite helpful, particularly in my bradykinetic rigid patients when dopamine itself was not sufficient. Another idea, I remember when we were talking about tone, is impacting the tone of the muscles so that you can relax them to help the amplitude of the tremor. And that is through toxin. This is not widely utilized as a treatment strategy. And I think that's unfortunate because it can be quite helpful, especially if patients are not tolerating medicines due to side effects, or their medicines aren't helpful enough, and you want to have a little adjunct to give them. You can inject the flexor muscles doing toxin. And again, that can alter the tone of the appendage and help decrease the amplitude of the tremor to make it more manageable. Helpful for dystonic tremor, especially because toxin is the mainstay of treatment for dystonia. Helpful for cervical dystonia, cervical dystonic tremor of the neck, essential tremor of the neck, you know, shades of gray in making that diagnosis clinically. So it is something to consider and as an option when medicine is not necessarily the most beneficial. And surgical management of tremor.
About this in the preoperative area, in our pre-surgical area, in the clinic. You're fine with us videotaping you and showing your face, correct? Okay, we appreciate that because I think it will help people. What we're going to do is periodically throughout the case, use some other videotaping to make sure that we're able to document the steps of your procedure. Okay, Dale? All right, we're gonna get started now, Dale. Thank you. Yeah, that's flow target on the over one below targets. Okay, we're in the right brain, right side of the hemisphere, and we're in the posterior tract. Okay, we're going to go on now. Monitor Millian, ready and on. Okay, wow, Dale, sweet. That's a sweet spot, baby. Hey, I like that. Not so bad. You're gonna be drumming again.
So that's surgical management of Parkinson's tremor, and that's Dr. Adam Sarkar, our own functional neurosurgeon at GNI, and he has given wonderful presentations and grand rounds on surgical interventions for tremor as well. If you haven't seen them, they're probably on our website and you can take a look at them. But for patients with tremor predominant Parkinson's, as this patient had, you could see he had the rest tremor, but also the action tremor. So he was that mixed type of tremor. It can be this impactful, this immediately. It is an awake surgery. It can be done asleep. I'm biased to having it done awake, as is Dr. Sarkar, because it allows you to be able to check symptom improvement. So if there isn't a response like that on the table, then things can be adjusted in real time, as opposed to having to go back and do any repositioning after the fact. For the idea of patients who are a candidate for DBS, absolutely tremor predominant. Early on, I mean, there are studies, early STIM studies, things like that, that say you don't have to wait and go through the cadre of all the medications and then say, okay, now you're a candidate. If you have tremor predominant symptoms that may or may not be responding to medications, after about 3 years of diagnosis and trial and error, you can really start thinking about surgery that early. For other patients, they've had Parkinson's for 5-10 years, and that therapeutic window is starting to narrow with the effectiveness of their medicines. That's the other time to think about doing DBS. Or you have patients that have had Parkinson's even longer, and they are kind of maxed out on their medications, and they're experiencing wild motor fluctuations, unpredictable off periods, or impactful dyskinesias. These patients are also a consideration and a candidate for DBS. The expectations of what DBS is going to do at each of these levels is obviously different. So early on, you might say, we'll reduce your meds and we'll just manage mostly through the stimulation. If someone is, further advanced, it might be, well, we're going to keep our meds the same. We won't have to increase them. And then we'll modulate the dyskinesias and things like that through the stimulation. So it's having that conversation, but there really is a very wide window of when DBS is appropriate. And unfortunately, people often think of it as a last resort, and it's not a last resort. And same thing for essential tremor. It was initially approved for essential tremor, but and then became approved for Parkinson's tremor. The targets are different. For essential tremor, it's the intermediate nucleus of the thalamus, but really that'll get to any tremor. For Parkinson's, it's STN or GPI. It kind of ebbs and flows in the culture of the movement disorder world, which is the preferred target. I happen to like STN. I think you get better medication reduction and tremor control. It's easier to program than GPI. Caveats for all of them, regardless of target: it can impact speech, it can impact balance, and gait is one of those questionable symptoms that may or may not respond to DBS, and you have to have a more nuanced conversation. If this is someone's gait that improves when their medicines are working and they can tell that, then yes, DBS should help that, of course, because it extends your on time. If their gait is not related to their medications, they have a lot of balance issues and retropulsion, but they also have a horrible tremor that you're trying to address, then you have to let them know, I can probably get your tremor under much better control, but that might impact your gait a little bit. And if you are comfortable with assuming a little bit of that risk, going through physical therapy, maybe needing to use a cane or a walking pole or something like that, these are the real conversations that you have to have. But it is still a conversation that should be had, because again, you can help one symptom significantly, and that might be what the patient really needs. So quick overview of other tremors. This is a drug-induced tremor, and you can see that this is sort of a fine, fast tremor that exists in all axes.
This individual, taking a combination of lithium and paroxetine, has a high frequency and low amplitude tremor of her hands while at rest in her lap.
นับเดือนให้หมอตัดสิครับมกราถึงธันวาคมนับเดือนให้หมอตัดสินับเดือนมกราถึงกุมภาไล่ไปเรื่อยๆสิครับผม
In addition, with her arms extended in front of her, she has a similar high frequency, slightly irregular postural tremor of both hands.
So the thing to notice there is that hers didn't stop with movement. It immediately persisted. So that's the idea, that this isn't just a rest tremor. This is an action postural kinetic tremor. And so this is a dystonic tremor, and you could just see sitting here, her shoulders are elevated on one side, and this tremor will be a lot slower, more jerky.
This patient exhibits a complex cervical dystonia producing left-sided rotational torticollis, right lateral collis, and right shoulder deviation. The dystonic head posture is associated with a mixed vertical or yes, and horizontal or no, tremulous and jerky head tremor.
She has a null point. So if you turn to one side or the other, the tremor will go away.
Your chin touch the head there. Okay, and back. Little. Okay. Now you put both hands up for me, please. Okay, put your right hand open and close your right hand. Okay, tap your finger like this. The left hand open and close your left hand. Okay, and tap your finger like this. Okay.
So that is, they're trying to show distraction or entrainment, and she's not. Like, that tremor is persisting through the movements. It doesn't change in its quality. It doesn't change in anything else. That, again, was part of the clinical exams that we were talking about before. A Holmes tremor is a slow rest tremor that's usually caused by a lesion or something, a bleed, a stroke, whatever it might have been. But you could see that that is a rest tremor without question. But look at how slow it is in comparison to a Parkinson's tremor. And there really would not be anything else on exam as far as rigidity, masked facies, cogwheeling, decrement, stuff like that. It also doesn't reemerge, but persists. Orthostatic tremor is a tremor that is, I wonder why that's not playing. Anyway, it came to a little bit of a resurgence in interest because of Angela Merkel. That's Angela Merkel. She had orthostatic tremor observed at a number of public engagements, and it basically happens when you stand and your legs tremor considerably, like quite quick and pronounced. This is what it looks like on EMG testing. You can hear it. It sounds like machine gun fire. It is something that if you didn't have an EMG to do, you can even put your stethoscope on someone's legs and hear it. I never have, but my attendings in fellowship said that they have heard orthostatic tremor. It's treated with clonazepam or with hydration. So it's something that, and it goes away with movement. It's only when you are, when you're standing still. So just something to keep an eye on. It is something that you will see in clinic. People will describe it and you'll say, oh, hey, yeah, I think I know what this is. And then there are pretty good managements for it. And then this is a wing beating tremor. I know we're running short on time, so I'll just move the video up to where it is. So, this person has so not on that side.
Ahora levante su brazo izquierdo. Baja derecho y levante izquierdo.
And then right there. And again, this is a really large amplitude, not a very common tremor at all, usually seen in something in the dendrorubal-thalamic pathway that is secondary to, again, some sort of lesion, infection, whatever it might be. Seen in MS, if there's a demyelination lesion. This doesn't have necessarily specific treatment. Muscle relaxants, sometimes toxin can be helpful, again, more so to make that limb more weak so that it doesn't have quite the amplitude that it impactful that it might be. But it looks like a wing beating. And this is a writer's tremor. And this is really to notice, to ask the person to do the thing that brings it out, because this person is completely still throughout the entire exam. And it is something that you would never know unless they actually were able to write for you during the exam. nothing with drinking. I'll bring it closer just to where he's writing. So here you can see when he brings the pen to paper, there's a hesitation and there's that kind of shaking until he really can get it down and going, but it interrupts him and he's got to focus to get it to touch. So for this, it's a task specific like dystonic tremor. And if they didn't want to go through toxin or an intervention, there's a pen called a pen again, which again changes the arc of the arm. They hook their index finger or their middle finger through it, and it might help enough that they don't feel like they need to do anything else. Again, weighted pens, large jumbo pens or pencils can help, all because it's changing that tone when they're writing. And so just some takeaways. Things can look a lot alike. So it's not uncommon for PD and ET, a tremor predominant PD or ET, to get, confused in the diagnosis. Cervical dystonia and ET of the head to get confused in diagnosis. There are strategies outside of medicines. So weighting strategies, ergonomic utensils, other than oral medicines, there's botulinum toxin, and surgery, like I said, is not the last resort. And if you ever had a question about something, feel free to video it and shoot me a text or an email. I'm happy to take a look. And so with that, we left a couple of minutes for questions.
Dr. Farmer, thank you. Great talk. I personally always enjoy your talks because you have that talent to boil down to, complex topic to the very simple explanation. We have several questions for you. Now, okay. Do all patients with Parkinson's disease have postural tremor?
No, they don't.
Head tremor. When somebody presents with a head tremor, so the differential you mentioned about the dystonic tremor, null point, etc. What about essential tremor in people with Parkinson's disease?
So if someone has a diagnosis of Parkinson's, either confirmed by response to medication or through DAT scan, but they also have an action tremor, then I call that a mixed tremor. Like, I don't give them two separate diagnoses because the Parkinson's takes the precedence. And then, but I will treat it separately if I need to. So if they're on levodopa, but it's not responding, then we could try a little propranolol, or if they're already on metoprolol, switch it to propranolol kind of a thing, or a little primidone. But if it's a head tremor, more specifically than medication changes, then I'm going to give them a little toxin, because that probably introduces the least amount of side effects or polypharmacy for that.
This is actually a very, very good question. It came through. And so your visual evaluation of the fast and slow tremors, I mean, nobody's counting those hertz.
No. No. Yeah.
So what is fast, what is slow for you?
Honestly, what looks fast and looks slow. Like, I mean, I'm not counting hertz per cycle. You know what I mean? Like that Holmes tremor, like that's a slow tremor. If it's like this, I'm going to say that that's moderately fast. If it's like this, then of course that's fast. So that's really kind of how I break it down. It's not, I say this to people all the time, especially when I'm arguing over the benefit of telemedicine and movement disorders. It's really not rocket science. Like, people overcomplicate it. If you can see it and you can put it into some categories to start your treatment and your differential, what you're seeing is there. You don't have to be uber specific about it.
Yeah, because sometimes you see, those recommendations, and it's going to be, 6 hertz or something like that.
Yeah. Yeah. No. Yes. Right.
Can tremor predominant Parkinson's disease present just with action?
It can. And that's what makes it so hard. And those are the people that are, like I said, misdiagnosed as essential tremor, appropriately so, because essential tremor is more common. It's going to affect people at a younger age and all of that. It's when either that person is not responding to what you would expect them to respond to for essential tremor, or you're doing the exam. And for me, when we tap the fingers and open and close the hands, this is part of the Unified Parkinson's Disease Rating Scale exam that we do at all visits. And it's the decrement. So someone with essential tremor, their tremor might impact it. So that might be a little incoordinated and they might be going like this, but they're staying at the same amplitude every time they do it. If they start to decrement or get smaller and smaller as they do it, then that's an indication to me that this might be a little bit more than just essential tremor, and I'd get a DAT scan. I will absolutely get a DAT scan if someone's coming to me for essential tremor of a number of years and it's a surgical evaluation, because I don't want to put the lead in the wrong spot, because while the VIM can help any tremor, it won't help rest tremor, which these people will eventually get later on. So I'd rather, preemptively place it to what they're going to need in the future, as opposed to just what they're having now.
So, now, functional tremor. So there is this clear overlay, organic and functional disorder. Like seizures, patients with seizures have pseudo-seizures. Patients with real amnesia also develop functional amnesia on top of that.
Yep.
You see frequent with people with actual diseases have also this functional component, and how do you manage that situation?
So I will manage the underlying condition and see how far we get, essentially. And if there is functional overlay to what they're already having, and that they're not completely responding, that's when I look to mood stuff. Like if they're not on anything for anxiety or depression, I'll have this conversation with them that, especially with Parkinson's disease, like dopamine is on a spectrum. If you're low in dopamine, you're also low in serotonin, you're also low in norepinephrine. And if you're stiff and rigid on the outside, you're going to be stiff and rigid on the inside when it comes to, being adaptable to new situations, or finding that you are, things don't roll off your back quite as easily. So we have to address that. And then sometimes that's enough, because the functional overlay in those patients oftentimes is situational. Like they're going out to a restaurant at dinner and they're like, I was so still this whole time, and all of a sudden my hands are like this. And so we kind of talk about it. That's where I may or may not use, depending on the intensity, a little bit of a benzo, as opposed to bringing on board a whole new medication regimen. If it's something that requires something daily, then like I said, I'll look to starting a Zoloft or a Lexapro or whatnot to see if that makes a difference. And then educating the patient, of course, as to why their tremor might increase. I have a whole conversation about you can't disentangle mood and movement. It is part of the same pathways in the brain. So of course, if you're kind of a little bit anxious, you're going to notice an improvement you're going to notice an increase in your motor symptoms. And if they are, feeling a little deflated by that, I'm like, well, think about people without Parkinson's. Like they're getting up to talk in front of a room and they're not used to doing it. All of a sudden their hands will shake or their voice will quiver or tremor. It's just enhancing the tremor that somebody already has. And your tremor is already more pronounced than most. So that's why it's enhancing it even more.
Amantadine. There is a clear indication people usually use it, medication-induced hyperkinetic symptoms, etc. Any other indication for amantadine type patients in the Parkinson's disease?
Yeah, so amantadine remember, that was the very first medicine that we had for Parkinson's. So it can be used monotherapy for things like tremor and stiffness and slowness and stuff. It's just that dopamine worked better than amantadine. But if levodopa isn't tolerated or it's not working or someone's incredibly young, you can use amantadine as monotherapy to try it out, see how they tolerate it. It's also used for off periods in Parkinson's because it was, again, used to treat any symptom. So it had fallen out of favor and was used more for the dyskinesia, but it can really be used for both. So the issue had been tolerability mostly. And then as the newer ones came out, some of the cost was cost prohibitive. But like I said, from an availability point of view, the newer meds are now more easily available. So if you liked using it, but haven't been because of the effort that it took to use, consider trying it again. But it's also, like I said, utilized not just for the dyskinesia, but off as well.
Okay, I'm going to squeeze in one or two more questions. Who is the ideal candidate for DUOPA?
Somebody who responds to Parkinson's, somebody who responds to carbidopa, levodopa, but has to take it incredibly frequently. So say you have somebody that's in that, they've shortened from that 6 hour to the 5 hour to the 4 hour, and now they're at like that 3 hour window. If they're getting a good response, it's just short and they're open to the idea, that's really the ideal candidate.
By the way, that subcutaneous pump sounds like it might be a revolution, actually.
It really would be. The thing that's going to make it not is coverage. But we're expecting that and hoping that there are ways that we can work around it. As long, if they approve, they're not going to approve it for initial therapy, obviously. But if they approve it for second line and not necessarily stepwise, like you have to fail adding on an MAOB or a COMT or whatever, like if you could go right from oral carbidopa-levodopa to infused, it really would be a game changer.
There are many adjuncts for Parkinson's disease. How do you select adjunct therapists for early moderate tremor predominant PD patients with predictable off episodes?
So if they are tremor predominant and responding to carbidopa-levodopa, I'm going to add the adjuncts that enhance carbidopa-levodopa. So that would either be adding a COMT inhibitor, whether it's entacapone that you take with each dose, or Ongentys, which you just take once daily at night, or I'm going to add an MAOB inhibitor. That doesn't necessarily have the same clinical strength as some of the others. It kind of works more subtly in the background, but I'm also of the camp that I think MAOB inhibitors may have a potential role in, maintaining stability of the disease for the long course. So I like to get those on board, especially for younger patients early on. But those, I'm going to, like I said, look at things that are going to enhance levodopa. If they're tolerating it well and they do get a response, it's just not sufficient. If then we need to add on secondary medicines to that with different mechanisms, if it's really tremor predominant, I'm looking at the dopamine agonists because they are going to have the next best benefit in reducing tremor. So that's sort of my approach.
Dr. Farmer, thank you very much. It was a great talk.
Thank you. Bye-bye.